Today I will be presenting on Talquetamab as a bridging option prior to BCMA CAR T therapy. So this article it was published in Blood in November 24. So starting with the background, as we all know, the anti-BCMA CAR T therapies like IV-cell and cilta-cel have revolutionized treatment of relapsed refractory multiple myeloma. However, there is this manufacturing period is there of 6 to 8 weeks, which often leads to disease progression and death in up to 25% of the patients, necessitating an effective bridging strategy. Talquetamab, it's a bispecific antibody targeting GPRC5D. It's approved for relapsed refractory multiple myeloma with 4 prior lines of therapy. The advantage of talquetamab is that it offers a rapid and a deep disease debulking without impacting BCMA. There's no cross resistance with BCMA therapies. So this study assesses the safety, efficacy of a short course of talquetamab as a bridging therapy for patients receiving cilta-cel or IV-cell. So, as mentioned previously, talquetamab it's a bispecific antibody targeting GPRC5D. It's approved for relapsed refractory multiple myelomas with individuals who have received 4 or more than 4 prior lines of therapies. It offers a rapid disease debulking and there's no cross resistance with BCMA directed therapies. So this study design, this was a multi-center, it was a retrospective study involving 14 US academic medical centers within the US Multiple Myeloma Immunotherapy Consortium. Patients with relapsed refractory multiple myeloma underwent leukapheresis and received TALC bridging therapy with the intent to proceed to commercial cilta-cel or ID-cell were included in this study. What were the outcomes evaluated? The outcomes evaluated were safety, feasibility, and efficacy. Safety in terms of cytokine release syndrome, ICANS, talquetamab-related unique toxicities such as skin-related disorders, taste-related disorders, nail changes, and related neurotoxicities. The patient demographics. The study included 77 patients. The median age was 66 years. The majority of the patients included in the study were difficult to treat cases. For example, 45% had high risk cytogenetics, 43% had extramedullary disease, and 73% cases were triple class refractory. The median prior lines of therapies received were 5, and in that 13% had received prior BCMA therapies. Talquetamab as a bridging options. Since 76% of the patients received bi-weekly talquetamab, means 0.8 mg per kg every 14 days, and other patients had received 0.8, 0.4 mg per kg weekly doses. The median duration of patients who were on talquetamab was 22 days. Only one cycle they had received. Response evaluation. The response was out of the 77 patients, the response was evaluable in 72 patients, and 45 patients out of 72 had achieved a response. Out of this 45, 14 had achieved an undetermined CR, 10 had achieved a VGPR, and 21 patients had achieved a partial response. Toxicities, there was no grade 3 or grade 4 CRS. There was 2.5% incidence of grade 3 ICANS. The most common side effects were talquetamab related unique toxicities. For example, the oral toxicities in 56%, skin toxicities in 41%, nail toxicities in 25%. But however, these toxicities were short lived and 60% had already resolved at the last follow up. Bridging success to CAR T therapies. So out of 77 patients, CAR T was successfully manufactured in 61 cases. 58 patients had received CAR therapies. Out of 58, 45 had received cilta-cel and 13 had received ID-cell. 3 patients had died pre-infusion due to disease progression. And till the last follow-up, 10 patients were yet to receive CAR Ts, and 6 had achieved, there was a manufacturing failure, so they didn't achieve CAR therapies. CAR therapy outcomes after talquetamab. 65% of patients had achieved experienced CRS. The incidence of high-grade CRS was only 3%. That is, grade 3 CRS was seen in two patients. ICANS 8.6% incidence, and grade 3 was seen only in one. Delayed neurotoxicities, one patient had developed a facial nerve palsy. There was no treatment-related deaths. Response evaluation to CAR therapies at day 30, it was evaluable in 40 patients. And out of this 40 patients, a response was seen in 39 patients, that is 97.5%. 14 had achieved a CR, 10 had achieved a VGPR, and 15 a partial response. Now, what is the washout period for talquetamab? Usually, the duration mentioned in the literature, it says 4 weeks. But this study, they didn't find any difference when the washout period was less than 24 days or more than 24 days. The median time from last talquetamab to CAR therapy was 25 days, and prior to lymphodepletion, it was 24 days. There was no significant adverse event difference was seen with talquetamab washout period duration. So to summarize, talquetamab is an excellent bridging option before BCMA targeted CAR therapies, showing high response rates even with short-term use and enabling most patients to receive CAR therapies. The most common toxicities are the oral, skin, and taste changes, which resolve after the last follow-up. This findings underscore the effectiveness of a short course of talquetamab bridging to maintain disease control and improve outcomes post